It's my great pleasure to introduce our guest speaker, Dr. Zara Marselian, CEO and President of La Maestra Health Centers. Zara has been a friend and a guest speaker in my courses for many years. She's also a client, as La Maestra has been using Patient Angle, a sister product to Class Angle that you're familiar with. I'm continually amazed by Dr. Marselian's passion and commitment in serving economically disadvantaged communities. Zara, it's great to see you again, and thank you for taking the time to be with us. Would you please tell us about La Maestra Health Centers and how IT projects help you in achieving your mission?
Well, thank you. First of all, I'm very honored to be here again and being able to impart some information that has been very useful for La Maestra as a nonprofit grassroots organization in City Heights, San Diego, and you'll see we have other sites, to be able to really make an impact on the well-being of vulnerable populations. And I'll, of course, provide you with the background so that you can see why we have adopted certain IT modalities and how we have tailored them to meet our needs. So with that, I'd like to move forward and introduce you to La Maestra. And we started in 1986, actually, as a nonprofit educational organization providing immigration assistance to 12,000 students for them to qualify for their amnesty program, phase 1, phase 2, and then many other applications ensued after that. Permanent residency became citizenship, then we helped a lot with political asylum cases, again, all involving tailoring IT systems to incorporate and track all of their studies and the services that they received, because the end goal was to help them mainstream into society. So of those 12,000 students, you can see from the slide, we offered also English as a second language, vocational training, we had a child care center. A lot of social determinants were at this first organization. And in 1990, the students said, you know what, we really need healthcare services that are culturally competent and meet our needs. And so we didn't know anything about healthcare, but we saw the incredible need, and we started La Maestra Family Clinic in 1990 with that patient, with the student base of 12,000. And now we are at, you can see from the map, we have different medical, dental, mental health sites. We have 4 school-based clinics. We also have a licensed mobile clinic that you'll see what it does in San Diego and with the different populations, again, all involving connectivity. We also have a mobile mammo coach, first in San Diego, and we have imaging at La Maestra for, we do breast biopsy, we do x-rays, ultrasounds, CT scan. We have a liver clinic we also use imaging for, and many other specialities aside from the breast health. And again, that involves, DR systems, establishing the connectivity, being able for the mobile mammo that's out on the road, sometimes in rural areas, to have those scans immediately read by our radiologists so that we know if we need to follow up with those patients if they have some abnormality. So being connected is what it's all about. And we really value and have invested a lot in our IT systems, as you will see as we progress through this presentation. Another, I think, very unique feature about La Maestra is that we have incredible culturally diverse populations, and our philosophy has always been to hire from the populations that we're serving to join us in our staff. And we, cultural alignment is very important to build the bond of, trusted relationships with the staff, for the staff to have that empathy for the patients that they're serving. That cultural alignment is very, very essential. And out of that, we have the medically trained cultural liaison program. So it's not just based by ethnicity and culture, it's based also on shared backgrounds. So you will see that we have staff operating, you know, our medication assisted treatment programs, behavioral health, that have also experienced substance use disorder. And so they're very, you know, they're trained, they have their certifications, but they're also dedicated to helping others that went down the paths that they did. Similar to our reentry programs for people that have served time in correctional facilities and they are mainstreaming again. Who do we have working with them? Are people, again, that share that background. And this model, this philosophy really does work, and it's incorporated throughout all of our services, medical and the social determinants of health programs that you'll see very shortly. So we have over 500 employees, and so you can see we've grown a lot in 30 years, and it's all determined by the needs that are present in the communities. Unduplicated patients, you can see fiscal year 2019, you know, we had over, you know, 45,000 patients, and you can see the total visits is slightly higher. Of course, with COVID, which I'll get into in a little bit, has really switched a lot of the inpatient visits to telephonic and telehealth, telemedicine. And we'll be talking about that. If La Maestra, of course, hadn't had such an investment in telehealth for years, since I think 2006, when it wasn't a popular investment for funders. It wasn't seen as, you know, attractive. They didn't understand the reason for it. If we hadn't found money from our operations to really fund these programs, we would not have been ready for COVID and being able to transition to telephonic and telehealth for more of our services. So these are some of the barriers that our populations face in terms of access in the community. And a lot of times they can't communicate because providers are not culturally competent. They have not embraced a model of competency to fit the understandings of the patient base. These are some of the difficulties that people face in terms of accessing care. Most recently has been the expanded public charge rule. Interfered with people, you know, accessing care. And you can see these others here, especially we're on the border with Mexico. So a lot of immigration issues, concerns about being reported if they access certain services, and is that going to lead to deportation? So we have a lot of work to do in terms of talking to people, listening to their situations, and pointing them in the right direction for resources. These are some of the physical health issues that are exacerbated by adverse social determinants. These are connected directly to chronic disease and to their overall well-being. And we have programs that address all of these, you know, illnesses. And prevention is a big key of what we do. What La Maestra has developed in terms of innovative models, the first one is the circle of care that I'll show you in a second. And that's an integrated model bringing social determinant services into an FQHC setting. That's federally qualified health center. In other words, it's a community clinic that has now incorporated and embraced many wellness services. And you can see the variety of the populations here, the programs, and again, the importance of establishing medical homes for these patients, and not just through inpatient care, but also through telehealth and telephonic visits, which is especially important in behavioral health and mental health services. We have found, as other FQHCs across the nation, that using this modality is much easier for people to call in and obtain those mental health services. They feel like there is a a physical distance. They're not looking at somebody's face right in front of them. So some of that embarrassment or that shame or guilt is removed if they are speaking, on the phone or through, telehealth. And we're able to reach many more people. And aside from the integrated model, you see that there are other models that have been developed that are very innovative among our peers across the nation. And one of them is a management team model. It replaces the COO model that really has ended up being a bottleneck. And we always find and train and keep growing people to become, emerging leaders for the future. And that's, I think, why our organization has been able to be very comprehensive and continue to be ahead of many other FQHCs in terms of developing some of these innovative programs. These are just some issues that patients have, and they seek care for mental and behavioral health issues. Again, stemming from poverty. And a lot of the results and the findings point to many similarities among our populations because they're all rooted in, the socioeconomic factor of being poor. These are some adverse social determinants in San Diego with the populations we work with. And you can see here that, people report feeling like they're isolated, they're marginalized, they're not included in, public health programs. They're, dropped from different systems because there's not enough case management. And so we really have at the center of our circle of care really focused on advanced case management models. So we don't drop people, we don't lose them, especially when they're high risk. And, we want to make sure that they obtain the resources that they can access through the pathways of our organization. This slide here came out of the work I did on my dissertation, and it was all about the effectiveness of an integrated model working with vulnerable populations. So you can see that all of them in the case studies were low income, and then with the additional layers of complexity, they fall into these categories, and you add that to adverse social determinants that again stem from social, injustice and health inequity. And on top of that, the prior adverse life experiences, the traumas that they have been through, you end with some really complex issues that are connected to health specifically. This is our La Maestra Circle of Care model, and you can see the visual depiction of how the services are grouped by color. All of the red are medically related. All of the other colors are enabling services and social determinants. So you have economic development, housing, food scarcity programs, transportation, a lot of the social determinants. Housing, we work with different housing projects through the county, through the city. There's not enough housing in San Diego for, subsidized housing. And we have our own transitional housing and sober living units that we work with very closely, as you'll see as we move through the slides. This is a good slide that I took from, that I used in my dissertation to kind of break down the different social determinants and how they are all related. Well-being in the circle of care, is not just offering services like a trip to the doctor. There's a lot more to do with well-being, and it's, having people feel, socially connected, which deals directly with the feelings of isolation and being marginalized, having a support system, being able to access resources of information, and that builds social capital. And with that, self-esteem and, more relationships to, to feel like you're connected more and you can access more information. And aside from that, the other programs that do bring well-being are connected directly to health. So exercise, community gardens, food pantries, and programs to have people be able to reciprocate. And you can see here some of the youth programs, culture and art, affordable housing assistance, and helping people develop their own businesses through the microcredit and microenterprise assistance programs. This is another innovative model where we have really brought together behavioral health, mental health, and medical services. These are our partners that we have built through our networks that refer people to us, and we manage these clients. This is the staff that integrated model, works very well together. We have medication-assisted treatment programs. We're a certified behavioral health center. And again, we bring the cultural diversity to all of these models, this included. This is not only in-person, telephonic, telehealth, but we also go out through our mobile services, you'll see in a minute, and we're able to then bring people back into the circle of care and help them with their other needs as well. This is some of the access, other programs we offer for seniors, financial education for everybody, how to look at nutrition, especially if you're diabetic, if you have other chronic disease, or even to prevent that. We teach about, we have classes that people join. And now that, because of COVID, we're limited because of the social distancing, we offer these through Zoom and other modalities as well. This is some of the outreach programs that we do. We go out to homeless camps. We are called there by a lot of our partners. We do the outreach, and then again, the objective is trying to link people back into bigger resources. And how do we do that? Well, we have to track people. That's where IT is extremely essential. We track them not just for the services that they've received, but the pathways that they access through our referral systems. And not just within La Maestra, but with our partners as well. All, with, of course, observation of HIPAA and other regulatory agencies and programs. We also track, like, for example, through COVID now, we do a lot of home deliveries throughout the county. And that's, people are worried about getting out of their house, getting infected. So we will deliver the medications to their house. That all needs to be tracked through systems and monitored for quality assurance, and meeting our HEDIS measures, which is the health outcome measures that the federal government holds us very accountable for. And with reentry services, same things. We were working in the correctional facilities, bringing certain services there. Now, because of COVID, we have had to go, totally through telephonic, telehealth, especially for mental and behavioral health. So when people are released from the correctional facilities, they already have established relationships in the community such as ours, so they know where to come for additional resources. Human trafficking is another program assistance that we offer. We have 236 clients now from 32 countries. It's a lot of case management. Again, our systems had to be tailored to encompass the data that we are collecting and the case management modalities that we use to track people through their different referrals to outside organizations for their human trafficking assistance program. Immigration is another social determinant that's very, I would say, predictive of healthcare outcomes, because if people are very worried about being deported and or having the wage earner of the family deported, and what are they going to do? So they want to know about all of the applications that they qualify for, or perhaps already in the system that immigration has taken 3 or 5 years to resolve or to adjudicate. So these are some of the health, e-health and IT solutions. We talked about telehealth and the mobile clinics, the digital imaging, electronic health records. We use NextGen, and we've tailored it a lot to be able to now encompass the social determinants into one system. Before we, had developed our own tracking mechanisms for all of the non-medical services that we offer, but that's called, it was very difficult because the providers would have to, do dual entry and, jump from NextGen into QuickBase and so forth. So we were able to tailor the NextGen, the EHR system to be able to track and build client profiles that weren't yet patients, because NextGen, like all EHRs, only wants you to be able to enter information about current patients. Well, what if they're not patients yet and they've been through some of these other services? That was why we had to do a lot of work on that program. We also have I2I, which is a chronic disease management, and we always compare the data that is emanating from is pulled from one system to the other to make sure that that our reports are correct. Again, we do this for quality measures and for predictive analytics studies. We recently developed our own La Maestra app, which is awesome. And people are able to enter the app, access their patient portal, even though only 10% in their patient portal, they rather have that explanation by the provider and the support staff about their health and their progress. They're not, so they're, in social media, that's another, we use Facebook, Twitter, we of course have our website. And we feature a lot of the, promotions, healthcare promotions, and just being able to communicate with our patient base when COVID hit, and, and letting them know that telephonic visits were now available, and reaching out to them to know that they're still connected and they have that social support with La Maestra network. That was very important.
Could you share your screen again, please?
You see it now?
Not yet.
The one that says jam. It's this one. Can you see it?
I can see it. It's not in the slide. Okay, perfect now. Yes.
So some of the new programs that came about recently because of our different, sites and the mobile clinic and so forth, was the telehealth specialities. Dentistry became much more involved in telehealth because during COVID, we could only, according to CDC, we could only see emergency cases. So a lot was, using telehealth to try to determine and help patients that could not access, direct services for dental. Like if they had a crown that broke or the bridge came loose, what we could advise them to do before they could actually come in. Ophthalmology, same thing. Psychiatry and psychology, as well as the behavioral health that I've talked about, were very popular with the patient base. Medication management, speaking with the pharmacy consultants about managing and how well were they doing with their medications. Did we need to increase the dosage? Of course, working in conjunction with the medical providers. That was supremely important. And again, radiology continued to be very important during COVID, with, of course, the guidelines from CDC of what we could start off with and what cases we could see. And as things started opening up again, we could provide more radiology. Also, the medication management, pharmacy consultation, super important in patient care, telemonitoring with patients with chronic health failure, heart failure, and we've just established specialty clinics around liver, diabetes, hypertension, asthma, and I'm sure the list will grow. This involves many different units, health education, of course, the providers, the pharmacy consult, and again, all of those programs have to be, there has to be connectivity because like pharmacies on its own standalone management system, data management and inventory. So is, lab. And so we've had to build those interfaces with our next gen and with I2I to make sure that we are seeing and capturing all of the data and being able to analyze it on a real-time basis for quality and case management purposes. This is again, through telehealth, we're able to reach out to specialists that are not available at our facilities. And that has been really a huge effort because many of these private practices, the specialists, their staff are not familiar with telehealth visits. So we've had to do a lot of training about, what equipment do you need? What are the protocols and procedures? How do you efficiently have a 15-minute visit? And what happens when you need a translator? And then what happens to the referrals? So it's really a lot about training all of the members of the group that are involved with these specialty telehealth visits. For those that are on our sites, it's much easier. Or for example, if we have a specialist at our City Heights, clinic that needs to provide a consultation to one of our outlying sites, that's something easy that we can do, and it increases access for our patients. They're not going to have to travel over there to access that service. So during COVID, just a little bit about that, right away, telehealth became a primary modality, and keeping the staff safe and the patients. We had to redirect workflows. We established a cough and cold clinic that we could divert patients that were presenting with symptoms before they got the testing done. And of course, at the beginning, the outbreak of COVID, the only testing modality that was available was working through one of these big labs that had, a 16-day delay on providing results. So we knew that, we couldn't continue to depend on these big labs, outside labs. So we got busy on securing our own, rapid testing machines. And now we do have one. It's called the Sophia machine. It's made through Medline, and we can get the results in 15 minutes for the COVID test. And it also has a download that we just finished, which would also test for the flu and respiratory infection. So that's awesome. And very helpful because people are trying to get back to work. They want to know if they're, if they have COVID or not. And then, obviously help them with their symptoms. Emergency dental, again, we had to purchase air filtration systems. We have fit mask testing. There's a machine that tests exactly if the mask is fitting properly. And we had to, learn about that. We had to train on that. Of course, we had to redevelop our whole, waiting areas for the social distancing. We also provided drive-through testing and a community outreach and letting people know in the community that these services were available was paramount to us meeting the consequences for COVID. This talks a little bit about our PPE supplies, and this was another huge effort, was to secure the amount of protective gear that was necessary, the equipment, and through the state and county it wasn't enough, so we had to work with our vendors and compete with everybody else, all the other healthcare providers like the hospitals that needed all of this equipment. And now we're preparing for the second wave, so we just answered more surveys for the county on what our projections are going to be. La Maestra has always had a higher rate of COVID than the average for San Diego County because our communities are higher risk for COVID. And so to give you an example, if the county was at 7 to 9% positive rate, La Maestra was at 23% or 19%. Now it was down to, I think, 16%, but now it's going back up because they say there's a second wave. And a lot has contributed to that. You know, some schools had tried to go back to, you know, in-person classes. The university, San Diego State University, just had like 890 cases when they brought people back to the dormitories. And that brought the average for San Diego County higher because of those, you know, because of San Diego State. So we're trying to monitor that. And now with the flu season coming, many people will be worried that their symptoms are very similar, you know, from the flu to COVID. They don't know what it is. And so we will be, I'm sure, dealing with that, and we're ready for it. So, you know, aside from the physical changes to our facilities with the plexiglass and, you know, everybody with the protective gear and the social distancing and people waiting in their cars, we text them to come in for their appointments so we don't have a bunch of crowds there. We still have a lot of walk-in people and in our cough and cold clinic as well, so we can keep well visits in one building and, you know, those that are symptomatic go into another building. So it's looking at pathways. So what does all of this data tell us? And how do we use the data, and how did we, you know, tailor the systems to be able to use the data in a real-time response and in decision-making matrix? So this is our, you know, SSRS system from NextGen, and, you know, that's our practice management, and that integrates with our population health management, I2I, the DR is for imaging, lab interface, e-prescribing. I mean, all of these systems have to be coordinated and customized, and then we're able to identify trends that emerge, and where are some gaps, and is this data valid? You know, have we compared it to our other systems? And what's the difference now versus, you know, a year ago now or 6 months before? So it's really very informative, and it allows us to streamline our, you know, the changes that we're making or addressing certain issues. Also, this all of these reports then are, you know, they need templates, and, you know, what do you do with that data, and how does it align with some of our other templates like Prepare, they call it. It's a social determinants template that was designed through the National Association of Health, Community Health Centers. We were one of the pilots because we'd already been involved with social determinants for years. I mean, we've been building it for 30 years, this model. And how does that fit into the referrals and the loops and better case management? And are all of the departments in sync, or are there certain gaps? And that's what the data tells us, aside from the quality metrics and some predictive analytics studies. Like one was, recent one was on diabetic patient adherence to medication, and looking at why people you know, fall into crisis with, or have to go to the emergency room when they're diabetic, and what happened there. Getting all of that data from the managed care plans as well as our systems, and seeing that it had to do with the patient adherence to and compliance with their meds. It's not of their own choice that they were not compliant with the meds. It's because, as we found out, their plans would drop them, or they would be defaulted onto another managed care plan. So by the time they hooked up with a provider that was approved under that new plan that they were defaulted with or to, their medication had already run out. So they would be like a week without medication. And if you're diabetic, I mean, that's a big problem. And many other, you know, chronic diseases has the same issue. So we looked at that, and we developed some suggestions from that predictive analytics, again, looking through our our systems and the data to see and identify what we could possibly implement. And we came out with some great suggestions. One was extending the prescription by, instead of 30 days, put it 35 days. So if it happens and it's right at the end of the month, they have that extra 5 days. Another issue that came out of that was the social determinants. The adverse social determinants really affect people in how they're able to take their medication or even get it. If they're worried about being displaced or they're thrown out because they can't pay the rent, they have other issues going on, they lose their job. A lot of this, and you can imagine in COVID, it's just gotten a lot more complicated. Managing all of the inventory of equipment, supplies for all of our services is incredible. That's also part of our data systems. And again, integrating and obtaining real-time information of how much impact our social determinants programs have on people's well-being. That's something we're always trying to measure. And it's difficult because you have to pinpoint one factor, and it a lot of times is not one factor. So and that's a whole presentation on of its own. This data has also allowed us to meet all of our health, our HEDIS measures as an FQHC and federally qualified health center. And we are actually one of the top 10% of health centers in terms of overall clinical performance. And that's because we also, part of QI is monitoring from a customer service perspective, which is why we have a lot of those innovative programs like cultural liaisons and the staff are aligned and, many outreach and social determinants programs, because that's what the people need. That's what they've said they need. And we have a pulse on that. How? Because who works with them are people from the same populations. So it's kind of, a logical reasoning there. But we measure that through real-time feedback through patient angle, which right away when a patient finishes services in an apartment, they have the option to get on an iPad, a laptop right there on a kiosk, and be able to choose, who is it that served them by the picture, the ID of that staff member, and provide immediate feedback. What that does is the result goes immediately to them, the staff member, the supervisor, and if they score like 3 or below out of 1 to 5, then it goes to HR. And we see if trends develop and we need to go back and do more training with that front office staff or whoever it was that they want to give comments on. We follow that up with, physical sheets, surveys at each one of our sites. So that way we can see what the correlations are between the results of the customer service ratings. Also, of course, there's, the social media, right? We monitor that as well. We get back to patients. And so looking at different ways of assessing the satisfaction of the customer, because that's what it's all about. That's what quality is. And being able to know on a real-time basis and be able to come up with some solutions to implement. So that is, and then there's this one also for the QI for, diabetes health. And we have others, as well, but I figured that this was a good, these were good slides so that you could see like, okay, what does this all lead to? What difference did it make? And the fact that we've met all of our patient-centered medical home audits and, every other regulatory agency that monitors us all the time, including the managed care plans. So this has been, what we've created. This is what works for us. We do a lot of presentations nationwide about sharing this information, sharing this models that we've developed to fit the needs of our community and help others tailor their models, or if they want to build more services into their models. We have a lot of requests for this. And we're on advisory boards also nationwide for these different programs. And yeah, we'd love to share and make our resources available. So thank you, Farhad. That's my presentation.
That is wonderful, Zara. I continually get amazed by the changes that happen in La Maestra. You're continually evolving and and really getting into new area every time I hear this. And the other thing that is really impressive is the amount of integration you have been able to bring about your systems, so that you get the consolidated view of what is going on in your organization, and then uh, presumably most of your decisions are based on those. Do you want to make any comment about that? Because that is really impressive.
Yes, I think we've come a long way in terms of not just customizing the data systems, but the reporting, the analytics that's behind the data. You know, years ago, La Maestra and all of our peers, you know, we are all in these consortias, and it's like, gosh, you know, how can we get more real-time data, and what do we do with it, and how do you make changes based on that? I mean, really, it's a whole shift in philosophy, just like when everything was manual. You know, all the electronic health records were manual. Making that shift to electronic health records is amazing. It's also part of that whole learning curve, and so we made that curve, and I think that, you know, we've added a lot to it in terms of being able to tailor the systems to capture that, you know, whole, you know, the totality of the effect of this integrated model, and prove it through the data has been awesome. That's very effective. And we've also been able to inform policymakers and our our political representatives, right? So, so to affect change at a societal level, this is also super important. Being able to back up our models with data to prove the effectiveness of these services and the needs for funds.
Right. So, and this is in particularly interesting to a number of the students in the class, because a large number of my students are actually in the health informatics focus. So this is a really fascinating example of how a healthcare organization can bring about all these pieces of disparate systems, and bring them all together and be able to then use that in the decision-making process and having data-driven management style. I think that's impressive. Before I let you go, Zara, I would like to ask you one more question, and that is, clearly, over the years, you have made significant investments on your IT systems. And you, as the leader and the CEO of this organization, what are some of the thoughts and advices that you can give in terms of how do you make sure that your investments are in fact helping your business, and make sure that they don't go off track and become wasteful?
Yes, and I have seen that a lot, like certain trends. You know, vendors are always persecuting us to try to buy their system, and then they'll send me a lot of emails. Oh, you know, a lot of your peers, other health centers across the nation have dumped NextGen because of this. You know, they're always promising a new electronic health record system, practice management system that's going to be the end all, and then the CEO is not going to have to worry about this not working or that not fitting the need, you know, this feature or that feature. No, you have to really know the system. You have to have people on your staff that love to figure out how to make the system work, because it's a huge investment. And then the connectivity with all of your other systems, like the pharmacy and others that I've talked about, mental health and imaging, everything. It's like, you know, you can't just dump it and run with another because you think it's going to solve all your problems. You have to know fully what your system is going to do, how to make it work for you, and have all of your staff, including the providers, embrace these features that can be made so much easier for them. Like, I remember a lot of them were like, oh gosh, you know, it takes so long, you know, to get to move from one section of the electronic health record to the other. And, you know, you need to look for a new system. Well, no, it involved then going in, training them, developing drop screens for the majority of, what they're going to have to select on that, on that template or on that page in the electronic health record to make it easier for them. So you have to look at the ease for the user, the end user, which is going to be your providers and your staff, and provide that constant training. Hey guys, we can help you, streamline this. And if you use these drop down screens, it's going to make your life super easy. What can we have filled right away in here from the nurses? How can they help support you? Making things like just physical, making it easier for them, where you're locating their monitor in the room so their back isn't to the patient all the time. Things like that. Really embracing this modality and this wonderful pathway to customer service and quality of care, and understanding it's not a choice, not a choice. It's like some of our older physicians, when we had to go from manual charts to electronic health records, and they're like, well, we just don't want to do this. It's like, well, you know what? It's we don't have a choice. I don't either, but I have to learn about it because this is tomorrow and we want to be ahead of the game and we want to make your life easier and we want to be able to get this data faster so we can provide better patient care. And so it was a whole training and getting people on board, and that's what really worked. Otherwise they'll just be constantly searching for the package that's going to give them everything, and you feel like you're in the Wizard of Oz all the time. It's just not going to happen.
And I witnessed this when we were implementing patient angle in La Maestra, that the roles were very clear, that you had the executive sponsorship, the overview of what you wanted to get, but at the same time, you had your quality improvement folks to be intimately involved as the business owner for the application, and making sure that the IT folks have a pretty good understanding of what their needs are going to be. And I think that's a combination of having that overview and the benefit of the top view, and then having the actual people who are going to be using these as tools for their work. I think that's an amazing combination.
Yes, and our board looks forward to these reports for the customer service results every month. It's part of the QI report, and we have a QI committee of the board. And let me tell you, they go through this and they look at everything, because in the end, that's why they're there, is to serve the community. So it's all about.
Yes. Thank you so much, Zara. I think we may have lost
customer service, and that feedback is awesome. Yeah.
Oh, I'm sorry. There was a short freeze, and I thought we may have lost you. But again, thank you so much for taking the time and sharing your wisdom and your experience with La Maestra with us.
Oh, it's a pleasure as always. And if there's any questions, or if you'd like me to attend any of your sessions for questions or for further dialogue around any of these topics, or perhaps others that I haven't included, I'd be very happy to do so. Just let me know. And thank you again.
Wonderful. Thank you so much. And I'm going to take you up on that, and we'll see if you can fit that in your schedule. I would like to have you in one of our synchronous sessions that we have, just for briefly to have some interaction with our students. And as you know, I share the email address so that they can actually connect with you through LinkedIn and the like. And I know that you have indicated that you don't mind students reaching out to you through those means, and I'm grateful for that as well.
Sure. Any advice? I'll be happy to, to be here to give it. So thank you again. Have a wonderful day.
Thank you. You too.
Bye-bye.
Great, Zara. Thank you so much. I appreciate it. I'm stopping the recording, but as always, you did such a fantastic